So now we will read about the pain assessment. Mainly in case of pain assessment, systemic assessment includes eliciting the following thing. There are mainly 8 things. One is what is the type of pain, periodicity of pain, location, intensity, modifying factors, effect of treatment, functional impact, and impact on patient. First, the type of pain, whether it is thrombin, cramping, or burning. Periodicity, continuous with or without exacerbation. Third is location. 4 is intensity. 5 is modifying factors. 6 is effect of treatment. 7 is functional impact. 8 is impact on the patient. These are the things which we use for the pain assessment. And there are pain assessment scales like visual analog scale, brief pain inventory, or numerical pain rating scale. So how to intervene the pain? So in case of intervene the pain, like if we are using the mainly is the pain medications. In pain medications, especially we use the analgesic ladder or three-step approach. That is, first is non-opioid analgesics. Second is mild opioids. Third is strong opioids with or without adjuvants. So there is a 3-step analgesic ladder approach which was given by WHO. First is non-opioid analgesics. Second is mild opioids. Third is strong opioids. So non-opioid analgesics, especially NSAIDs. These NSAIDs are used for mild pain. They work by inhibiting the peripheral prostaglandins and reducing the inflammation, but they also have the central nervous system effects, and NSAIDs have a ceiling effect also. And ibuprofen up to 2400 mg by day has a minimal risk of causing bleeding and renal impairment and is a good initial choice. But in patients with a history of severe GI bleed, whoever has severe GI bleed, brufen should be avoided, and in patients with history of mild gastritis, acid lowering therapy such as proton pump inhibitor should be used. And acetaminophen is an alternative in patients with history of GI bleed and can be used safely up to 4 grams per day. And in patients with liver dysfunction due to metastasis or other causes, or in patients with heavy alcohol use, doses should be reduced. If non-opioid analgesics are insufficient, opioids should be introduced, and opioids primarily work by interacting with mu-opioid receptors to activate pain inhibitory neurons in the nervous system. This point we should remember, that is mu-opioid receptors to activate pain inhibitory neurons in the CNS, and they also interact variably with delta and kappa receptors. And receptor agonists such as morphine, codeine, and fentanyl produce analgesia by activating pain inhibitory neurons in the nervous system. Partial agonists such as buprenorphine have a ceiling effect for analgesia and a lower potential for abuse. They are useful for the post-acute pain but should not be used for the chronic pain. So this point should be remembered, that buprenorphine should not be used for the chronic pain. And pure antagonists such as naloxone and methylnaltrexone are used for the reversal of opioid effects. So traditionally, when weak opioids such as codeines are used first, if they fail to relieve the pain, strong opioids like morphine are used. But there is a concept there where we are not using no longer terms called as weak and strong opioids, because smaller doses of stronger opioids is better than larger doses of weaker opioids. And for continuous pain, opioids should be administered on the regular around the clock basis consistent with the duration of analgesia. They should not be provided only when the patient experiences the pain. The goal is to prevent the patient from experiencing the pain. And patients should also be provided with the rescue medication such as liquid morphine for breakthrough pain, generally at 20% of the baseline dose. And the patient should be informed that using rescue medication does not obviate the need to take the next standard dose. And if the patient pain remains uncontrolled after 24 hours and reoccurs before the next day, requiring the patient to utilize the rescue medication, the daily opioid dose can be increased by the total dose of rescue medication used by the patient, or by 50% of the standing opioid daily dose for moderate pain and 100% for the severe pain.